Hi team, I hope you guys are doing well. It's good to see you guys, which I can't see you, but I know you're listening, okay? So I hope everybody's doing good. And I'm trying to do your voice over PowerPoint, okay? Now, this is what you guys agreed that you guys wanted me to do for you guys for this because this is the material we would have went over on Tuesday, but you guys agreed that you guys wanted me to do the voiceover PowerPoint so that way we can have the review on Tuesday. So I want you guys to listen to this before you come to lecture on Tuesday. Also, go back and study your notes for the other two sections because when you come to the review, I want you guys prepared to ask me questions. I want you to be able to answer the questions that I answer. And if you're not prepared, you're just going to be sitting there taking notes the whole time. And the thing is, then that means you're just going to be trying to cram to get it all in. So I want you guys to get as much as you can out of this, okay? I'm taking my time to make this for you guys, which I'm more than happy to do. But I also want you guys to be able to listen. Then you can bring me questions on Tuesday about any material that you don't understand, okay? Because everything I do is for you guys, okay? So, like I said, you guys agreed that this is what you wanted and that you would review this before coming to the review on Tuesday. Because if I'm asking questions and you're just sitting there looking at me, I'm going to sit there and look at you back, all right? And then I'm going to tell you to go look it up, all right? So, that's fair, isn't it? So I want you guys to be prepared for the first exam because this is the thing. I don't want you guys to sleep on the first exam because the second exam is going to be the hardest exam of the semester. So you guys definitely want to do well on this exam, okay? So like I said, I'm happy to do this, but I also want you guys to take the time to listen and come to me with questions and be able to understand this so that way you can participate in the review and like I said, not just sit there and look at me when I start asking the questions. Because if you sit there and look at me, I'm going to look at you back and tell you to go look it up, and then you're not going to like that, okay? So, anyway, please take the time to review this. And the cool thing about this being online is that you can stop it, you can go back. So, hopefully, you can get a lot out of this, okay? And you guys know I'm not the best with technology, so hopefully, this is going to be an easy and smooth transition, okay? So, this is the care of high risk clients, care of high risk antepartum clients. This comes from chapter 7 in your book. It's going to start on page 153. And and even though the title says complications of pregnancy, this is care of high risk clients, okay, of antepartum. And I do say the need to knows, okay? So, my inspirational saying of the week. First of all, do you guys remember the inspirational saying of last week? Anybody? Okay. Okay, that's all right. I'm sure you do. Stay motivated. So this week is stay dedicated, all right? Because this is the thing. I know a lot of people said, oh, being peds is easy. Well, I don't know about all that, but it's a lot of work, okay? And it's a lot of information. So stay dedicated, stay focused, and stay motivated, okay? Now, can we get a stay dedicated on three? One, two, three. Well, that was weak. That was weak. Can we at least get a ooh, ooh? All right, that was even weaker, and I'm sure nobody did it, but that's okay. And if you did it, ooh, cool, all right? And I do try to be funny and engaging online too, okay? So when I say the care of high risk antepartum clients, what do you think of? What comes to your mind? You know, basically, these are patients who are going to have issues. I shouldn't say issues. Actually, we all have issues. I have issues. We should get it. I need to get a t-shirt that says I have issues. But anyway, getting back to the lecture, care of high risk antepartum clients. These are clients who, we worry about who have disorders or maybe advanced maternal age. Do you guys remember advanced maternal age? What is that? 35 and higher. So these are clients who are going to have more issues and complications and stuff. So this is going to make them more higher risk. Okay. So anyway, gestational complications. So this is on page 154 in your book. Okay, so basically, your high risk pregnancy is going to be one or greater risk of the mother or the fetus or both than an uncomplicated pregnancy. So, like I said, it could be advanced maternal age. If you're advanced maternal age, that automatically makes you higher risk for pregnancy. All right, or if you have a genetic issue or if you have some sort of disorder, that's going to make you higher risk. And then your health problems before or during the pregnancy can increase the risk of the pregnancy. So health problems before or during pregnancy increases the risk of complications such as diabetes, obesity, hypertension, thyroid disorders, motility disorders, blood disorders. These actions can lead to more issues with the pregnancy. Risk assessment. So this is why we need to have the patients do really good prenatal care. They need to come into their screenings. They need to keep their appointments and not cancel, because this way we can do diagnostics and we can kind of identify anything that's going wrong. And then you've got your different risk factors, such as your demographic, medical, obstetric. Do they have issues in their last few pregnancies, social cultures, lifestyle, environment? So, these are all things we can look at to help identify any issues. Okay, so high risk response, we got responses to high risk pregnancies. Okay, so responses to the high risk pregnancies, these are issues that the woman goes through in response to complications during the pregnancy. So take a look at these different lists. Okay, stress and anxiety. First of all, is stress and anxiety good for anybody? Absolutely not. Nursing students, I'm pretty sure you guys are always stressed and anxious. Can you imagine being pregnant? And I've had lots of students who are pregnant in nursing school. More power to you guys, okay? But I know that that was probably rough. And this is on page 155 in the book. So these are all things that can lead to more complications, because we know stress can lead to high blood pressure, right? So the thing is, these are some of the different things that can be an issue and can be a response to high risk pregnancy. So these are things that we kind of want to look at, so that way we can try to figure out how we can best support the patient. Okay, so we also want to be a very good communicator, all right? Because this is the thing. We want to have a really good rapport, as we should with all of our patients, regardless of what the area. But yeah, the thing is, we want to make sure that we're listening well. We want to provide a lot of time for them to talk about feelings and concerns. We don't want to just look at their watch, look at their watch, look at the watch. We want to make sure we give time, opportunity to express feelings and concerns, and that's kind of a reason why. Remember the cheapskate pregnant lady? Yeah, I can see a lot of you guys were probably getting annoyed with her, but then when you took the time to actually talk to her, then she kind of came around. But I know a lot of people were getting annoyed, like, why is she asking me for everything? She needs to stop. But like I said, you want to give time, you want to give opportunity to talk about concerns, active listening, you know, repeat if necessary. So you want to be a skilled communicator. Nurses need to be aware of any barriers that may affect healthcare. You also want to encourage the woman and her family to participate in decision making, because that's going to give her what? What is it term when we let them participate and make decisions? Autonomy, okay? So we want to make sure we give good autonomy. Okay, now we're on page 156 to 157, okay? So these are just some of the different terms. So preterm labor, that's when you're starting to have contractions and the uterus is starting to have change before 37 weeks, okay? And when you start to have contraction, when the uterus contracts, that means that the baby is starting to come, is starting to move, and we don't want that if they're preterm. Then you got preterm birth. And preterm, what did we say preterm is? Remember what we said preterm was? Anything below 37 weeks gestation. Okay, and then you've got later preterm, okay? So, but like I said, we use these terms, in conjunction with each other. Okay, so now we're going to talk some about preterm births, okay? And we're still on page 156 to 157, okay? So preterm birth. The thing is, we want the baby to stay in mommy as long as baby can, all right? Because baby needs to be fully cooked, or as much cooked as possible, okay? So the thing is, preterm birth is the leading cause of neonatal mortality and the most common reason for antepartum hospitalizations. I mean, because if we worry about the baby being preterm, then we're going to be the patient's going to be hospitalized, so we can keep an eye on her, because if she has a baby, she needs to be in the hospital, okay? So we need to keep a close eye on preterm births and because these are going to result in preterm labor. All right, is everybody still with me? We still rocking and rolling, moving and grooving? We're still on page 157, okay? So let's look at some of the things that can cause the spontaneous preterm labor, okay? Like we said, it's the unplanned delivery before 37 weeks, okay? And then like hemorrhage, placental abruptions. We're going to talk more about placental issues later in this PowerPoint today, but placental abruption is when the placenta becomes detached from the wall. That's going to lead to hemorrhage, and that's going to lead to more issues. Okay, mechanical factors. uterine overdistension, or cervical incompetency Cervical incompetency is when the cervix is not working and it doesn't stay closed, and then the baby can come out. Hormonal changes, changes caused by fetal or maternal stress. Stress, there's that word again, that can cause problems, infections, inflammation. So these are some of the different factors that can cause spontaneous preterm labor. And also a history of preterm is the strongest predictor. Okay. All right, and then you have medically indicated preterm birth, all right? So, in these cases, we need to go ahead and deliver the baby due to medical conditions because what's happening is with the mom being pregnant, this is leading to all sorts of complications for mom, and then mom is going to be at danger if we do not have this baby, okay? So, in these cases, the healthcare providers often take steps to keep the baby inside of mom as long as possible to allow the baby to stay inside of the mom so the baby can have more time and allow additional time for birth. These patients are closely monitored, the mom and baby, for health issues. Different interventions are used, such as steroids. Steroids are given to the mom to help with fetal lung development. So some of the issues, medically indicated preterm, like I said, we're going to try to keep you pregnant as long as possible, but in some cases we may have to go ahead and have the baby if you know if it's affecting the mom. So preeclampsia, which we're going to talk about these issues later in the PowerPoint. Preeclampsia is going to be your high blood pressure, gestational hypertension, high blood pressure in pregnancy, placental abruption, and there's a lot of placental disorders, and that's when the placenta detaches from the uterine wall. IUGR, intrauterine growth restriction, that is super small baby. So something that you can think about is what do you think we're going to want to do for the baby? What are we going to want to do for the patient? What are some things that we're going to want to do for these types of disorders? And like I said, we're going to talk about this more, as we move forward. But this is just some things to think about. What can we do for this, basically? Okay, and like I said, we're on page 157 in the book. Okay, so preterm. Preterm or premature infant is is a baby that's born before 37 weeks, okay? Or 36 and 6/7, which 36 and 6/7 is pretty much 37 weeks, okay? So like we had said already, your preterm baby is going to be before 37 weeks. Late preterm is an infant born between 34 to 37 weeks, okay? So your preterm, but that's later. So the baby's going to have more of a better chance because baby, even though we're still preterm, that's considered late preterm. So like I said, we're almost there. So these babies going to have a much better chance. Then you've got very preterm. That's an infant born before 32 weeks gestation. Okay, so we still have a chance, but the thing is the baby's not gonna, the baby is gonna have more complications because baby's less developed. Variability, that's the threshold of variability is at 25 weeks, okay? So if the baby is born at 25 weeks, that is the time of viability, okay? So baby will have a chance at life. Periviability is going to be very early births. Neonatal death rate is very high. These births can occur between 20 weeks to 25 weeks gestation. So that's pre-variability. The baby has a very, very high death rate, a high rate of death because the baby was not able to be in utero as long as baby needed to be. All right, and if anybody has questions, please be sure to write them down so you can reach out. You can ask me later, or either we can talk about it on Tuesday when we have our get together for the review, okay? But please be sure to take down any questions so that way you can reach out to me later, okay? All right, so complications of your preterm infant, which we're still on page 157. So what I want you guys to think about this. What are some complications of the preterm infant? What are some problems that a baby being born too early can have? So some of the issues are cerebral palsy, hearing and vision issues, chronic lung disease because their lungs were not mature enough, and then other issues as well. So this is kind of why we want to try to keep mom as pregnant as possible. Okay, so preterm labor. So there's different reasons why somebody can have preterm labor, okay? One of the main ones is if you have a history of this. If you've had this before, we're going to keep a close eye on you. There's different reasons why, it could be due to disorders, or either a history, but it's not very well understood because there's different reasons why. And all of this stuff so far is just nice to know, okay? Believe me, when we get to the need to knows, you're going to know, okay? So this is on page 158, okay? That preterm labor is kind of not well understood. Okay, so page 159. So most common risk factors for preterm birth. So what do you think the most common risk factors are for this, okay? Because it's good to know what the risk factors are so you can understand it better. Like we've already said, prior preterm birth, multiple gestations, like if you have twins or triplets, sometimes twins can be full term, but the majority of the time they're going to be preterm, okay? Because they're running out of space in there, and like I said, the babies are going to need more than mom can give at a point when they get to a certain age. So multiple gestation, uterine or cervical abnormalities, or shortened cervical length. These are some of the most common risk factors for preterm births and preterm labor. All right. So, page 160 to 162. So now let's talk about how we're going to manage preterm birth and preterm labor. So now it's time for our need to knows, okay? Like I said, this is on page 160 to 162. So these are need to know. So yes, you have to know this, okay? And like in lecture, when I say something's a need to know, you need to know it, okay? So let's talk some about the medications, okay? So I want you guys to take a look at these meds. You have nifedipine, indomethacin, terbutaline, or magnesium sulfate, okay? Now, what is it? I'm pretty sure you know what nifedipine is, right? Medi Nifedipine is used for blood pressure. Now, a lot of these meds are used interchangeably, okay? So this is why I want you to pay close attention to the medical management. Do not mix up these meds, okay? Let's say it again. Let's not mix up these meds, okay? So we're going to want to give tocolytics, okay? Tocolytics are medications that we typically give to help to suppress contractions. Suppress contractions means to stop the contractions. We use these up to 48 hours to allow administration of the antenatal steroids, okay? And we're going to talk about the antenatal steroids really soon. So these meds are used to suppress uterine contractions. Need to know, okay? Hint, hint, wink, wink, okay? Terbutaline, nifedipine, magnesium sulfate, and indomethacin. Okay, so nifedipine, even though that's used for blood pressure, that is used as a tocolytic, and that's going to help to, stop the contractions, okay? And magnesium sulfate, that's actually used. We actually use that for preeclampsia, and for preeclampsia, we use it to stop, to not have a seizure because if your blood pressure gets too high, that can cause a seizure. But magnesium sulfate, is caused that we use that to help decrease the rate of cerebral palsy in the baby. Okay, but basically these drugs that you see, these are going to be used as tocolytics to help stop and suppress our contractions, okay? Progesterone. So this is also neat to know. We like to give progesterone supplementations. This can be helpful for clients with a history of spontaneous preterm birth. Okay, so all of this so far is neat to know. Okay, so progesterone, we give that. And that's helpful for a client with a history of spontaneous births, okay, for spontaneous preterm birth. And like we said, magnesium sulfate, that's used for neuroprotection to help prevent cerebral palsy for the baby. We give her cerclage. We do that for incompetent cervix, which we'll talk about more later in this PowerPoint. Cerclage replacements is prior to 24 weeks gestation, okay? And then we're going to give the antenatal steroids between 24 to 34 weeks of gestation. Okay, so this is all need to know stuff, so make sure you know it. If you didn't get it, just go back and rewind, okay? Okay, so page 163 in the book, let's talk some about the antenatal corticosteroids, okay? So you want to be sure you know the meds for this. So this is recommended between 24 to 34 weeks gestation and preterm labor are at risk for delivery in the next 7 days. So corticosteroids, what do they do? Okay, they're going to stimulate the production of more mature surfactant in the fetal lungs to prevent respiratory distress syndrome and premature infant. This helps to promote development of the fetal lungs if the woman develops early. So these meds are going to promote fetal lung maturity. I'll say that again. These meds are going to promote fetal lung maturity. All of this is need to know, okay? So your medication is going to be betamethasone and dexamethasone. These are antenatal corticosteroids, and we give this because it's going to help to develop the fetal lungs in case the mom delivers early, okay? So this is all need to know, okay? Adverse effects, this can raise the blood pressure. This can raise your blood sugar. It may require temporary insulin coverage to maintain blood sugars in diabetic women because corticosteroids, they do raise the blood sugar. So we're going to want to check the blood sugars for the women, especially, women who may be diabetic. Okay. So all of this is need to know. Make sure you know it and not just know it. I want you to understand it. Okay. So this is why it's not just memorizing it, you need to understand it, okay? So this is why I give you the need to knows because I want you to make sure you understand why this is, okay? All right, this is also something I want you to know, okay? This is the leafing space being, I cannot say this. If somebody's better at saying this than me, have at it. This is the LS ratio, okay? So you want to be sure to know this and know what it means. So the LS ratio of 2.1 or more indicates fetal lung maturity. If you have a low risk of infant respiratory distress syndrome, if you have an LS ratio less than 1.5, that's associated with high risk infant respiratory distress syndrome. So, this is something you need to know. I cannot say this word to save my life, but this is the LS ratio. It measures your fetal lung maturity. So, if it's 2.1 or higher, that means a lower risk of infant respiratory distress syndrome. If it's a LS ratio of less than 1.5, then you're going to have a higher risk. So, here's an example. Let's say the LS ratio is 3. Is that going to indicate a low risk of respiratory distress syndrome or a higher risk? 3, if it's 3. That means that's a lower risk because it's less than 2.1. Let's say you have an LS ratio of zero point 0.5. What would you say that is? Is that a high risk or a low risk? That would be a high risk of respiratory distress syndrome. So you do need to make sure you know that, okay? All right, now we're on page 165. And like I said, if you have questions, please be sure to write them down so that way you can reach out later or we can go over your questions on Tuesday for class, okay? And I'll probably do like an overview, okay, for this in class, just kind of an overview. Okay, so let's go over some of these signs for preterm labor, okay? Um, and these are also need to knows. You're going to need to know your warning signs of preterm labor. So what does BOW mean? You should know this from that terminology worksheet that we had for Skills Lab, okay? So BOW, bag of water, okay? So what do you think happens when the bag of water breaks? It means labor is impending. So that could be a higher risk for fever, and fever can indicate possibly infections. Okay, so make sure you know your signs and symptoms of preterm labor, such as low back aches, menstrual-like cramps, pelvic pressure, intestinal cramp with or without diarrhea, vaginal discharge, pelvic pressure, constant low dull back aches, contractions. Preterm labor is indicated by increased vaginal discharge, pelvic pressure, constant low back ache, which are common of labor beginning before 37 weeks, okay? So I want you to make sure that you have a good understanding of your preterm signs of preterm labor. And some of these signs and symptoms were not on the PowerPoint. So if you didn't get them, go back and listen, okay? So make sure you know your signs and symptoms, warning signs of preterm labor, okay? Also, menstrual-like cramps, increased pelvic discharge, a sensation of pelvic pressure pushing down. This could be indicated of preterm labor, like lower back pain, pelvic pressure, uterine contractions um, before 37 weeks, consistent with preterm labor, a sense of baby pushing down. That's all of these are signs and symptoms of warning signs of preterm labor. So make sure you know them, okay? And like I said, if you didn't get them, go back and listen, okay? All right. Page 165 to 166, okay? So let's go ahead and talk about PORM. PROM? What does PROM mean? Premature rupture of membrane, okay? So this means that the bag of water breaks before onset of labor, okay? So when you're PROM, this is like we call it rupture of membrane. That's when the bag of water breaks, but PROM is premature rupture of membrane. Okay, and then you have pre-prom. This is premature. this is preterm premature rupture of membrane. So this is when the bag of water breaks prior to labor and 37 weeks gestation. Okay, so these are the two terminologies. Okay, this just means that your bag of water has broken prematurity or preterm. Okay, so now we're going to be on page 168 in the book, okay? Now, has anybody heard of this? Cervical insufficiency? Has anyone heard of this? So what this can be referred to as an incompetent cervix. The cervix starts contracting and opening up, which could result in the developing the fetus falling out. Basically, the uterus can't stay closed, okay? So the diagnosis for this is a history of painless cervical dilation after the first trimester with expulsion of pregnancy in the second trimester, usually before 24 weeks, and absence of known cause. This may be congenital or acquired. Patients are typically asymptomatic but report symptoms such as backaches, uterine contractions, vaginal spotting, pelvic pressure, or vaginal discharge. So all of that is, this is, you know, cause the cervical insufficiency, or we call it cervical incompetent cervix. Like I said, this means that the cervix is not going to stay closed, because when you start to dilate, that means the cervix is opening when you're in labor. But this happens too early, and what happens is the fetus is developing, is going to end up falling out and miscarrying. So this is what we don't want, okay? All right. So we're on page 169. Okay, so has anybody heard of this? So let's talk some about the management, okay? Let's talk some about the management of this. So this is called a cerclage, and this is something I'm going to want to make sure you guys know. So this is the treatment of cervical insufficiency. So what happens is the cervix area is sewn shut, which prevents the cervix from opening prematurely. So this is your need to know, okay? The cerclage is going to help to support the cervix and reduce the risk of preterm delivery. Like we said, I'll say that again. The cerclage helps to support the cerclage and reduce the risk of preterm delivery. So you're going to need to know that, okay? So what are our indications? A history of second trimester pregnancy losses related to cervical insufficiency, prior cerclage due to painless cervical dilation in the second trimester, painless cervical dilation in the second trimester, current single pregnancy prior to preterm birth at less than 34 weeks gestation, a short cervical lead. Okay, so these are the indications for this. Okay, so what we're going to need to do, if the cervical change if the cervix change, painful contraction or vaginal bleeding progress or labor, the cerclage is removed. So this is what you're going to want to know. You're going to want to make sure you know when to remove this, okay? So it's going to need to be removed once the patient goes into labor, or if they have vaginal bleeding, painful contraction, vaginal bleeding progresses, or labor, then we're going to need to go ahead and take it out, okay? So we want to, after we have placed the cerclage, we're going to want to monitor for any uterine activity, monitor for vaginal bleeding and leaking, monitor for infection, and discharge teaching for this. And you're going to want to make sure you know your discharge teaching. You want to make sure you teach the patient to avoid heavy lifting and prolonged standing until the doctor says that it's going to be safe. And you want to make sure the patient know that they need to, that if they experience cramping, vaginal bleeding, or signs of infection, they need to contact the doctor. Also, the client needs to be advised to not have sexual intercourse until cleared by the healthcare provider to prevent complications such as infection or preterm labor. Okay? So the patients, and these are all need to knows, make sure you know your discharge teaching. So the patient needs to know to avoid heavy lifting or prolonged standing until the doctor says it's safe. Also, they need to let the doctor know if they have cramping, vaginal bleeding, or signs of infection. And they need to understand that this procedure is going to help prevent the cervix from opening early, okay? And so the thing is, like I said, these are all need to knows. And the thing is, just because they may have a history of this, that doesn't automatically mean that they're going to need the cerclage, but we are going to want to keep a close eye on them in case they need it, okay? But I do want to make sure you guys know what it is. Make sure you know patient teaching for this for discharge and when it's removed, okay? All right, hyperemesis gravidium. This is on page 173. Do you guys know what this is? Did anybody have to deal with this during pregnancy? So, what this is vomiting during pregnancy that leads to dehydration, electrolyte and acid base imbalance, starvation, ketosis, and weight loss. All right. Now, we're not just talking about morning sickness, okay? A lot of people have morning sickness. This is when you're vomiting so much, or it can lead to dehydration, electrolyte and acid base imbalances, and weight loss. So, what are some risk factors? So risk factors are history of hyperemesis in previous pregnancy, multiple gestation, history of migraine and motion sickness, familiar history, if you have a family history of it. So why do you think this could be such a problem? I mean, it's a problem because if you're throwing up all the time and you're not able to have anything down there for the baby, so the baby's not able to get the nutrients that they need. And so if you're already dehydrated, the baby's definitely not be able to get what they need from you or the placenta. So this is going to be problems for both, especially if you're having a lot of weight loss. If you have like 5% or more weight loss, it's definitely going to be a problem. Okay, so some signs and symptoms of this, and these are on page 174. Okay, you're going to see signs and symptoms of um, dehydration, such as lightheadedness, dizziness, fainting, tachycardia, inability to keep food down for more than 12 hours, dry mucous membrane, poor skin turgor, malaise, and low blood pressure. So these are going to be your signs and symptoms of possible dehydration, and you're going to see weight loss, ketosis, and vomiting may be prolonged, frequent, or severe. So this is a huge problem because you're not getting what you need, and neither is the baby. Okay, so what are we going to do for this? What are some things we're going to want to do for this? So we're going to want to give early treatment of nausea vomiting. So we're going to want to give medications to help stop the vomiting. And we're going to want to do lab studies because we need to check your electrolytes for this. Because if your electrolytes are out of whack, it can cause problems with your heart. And we want to make sure we have IV hydration. Um, we're going to want to give meds to stop the vomiting, and also we want to monitor your liver and kidney functions because, like I said, the thing is, this is going to lead to issues with your labs if you have dehydration issues. Okay. We're on page still we're on page 174. So what are some things we want to do for this? So we want to provide emotional support, comfort measures, administer IV hydration. We're going to want to check daily weights because we worry about weight loss. So we need to keep an eye on that, monitor I's and O's and labs, take prenatal vitamins before bed with a snack, minimize fluid with meals, exploring complementary therapy, reduce triggers. And so for this, I want you guys to make sure you know what it is and make sure that you guys know, like if you're having dehydration or major weight loss, like 5% or more, that's going to be a huge problem. Okay, so that's what I want you guys to remember from this. Okay. And like I said, make sure you keep track of any questions that you may have. I'll be more than happy to address any questions you have on this content, okay? Okay, next is diabetes. Okay, this is on page 175. So everybody should be familiar with diabetes. What can you tell me about diabetes? Did anyone have to deal with this during their pregnancy or know anyone with this? Okay, so like I said, you guys should already know what diabetes is because I know that you guys learned that from MedSearch, right? Okay, so type 1 diabetes, you know that it's an autoimmunity issue. Type 1 diabetes is managed with insulin. Type 2 diabetes is going to be managed with diet and exercise in addition to oral anti-hyperglycemics or insulin. Okay, so if you have like a blood glucose level of 140 after meal, it's slightly elevated but not critical, and it's to be expected that after you eat that your blood sugar may go up a little bit. Some women may develop diabetes during pregnancy, and this has to be managed. Did anyone have to deal with this during their pregnancy? So the thing is, you have type 1, type 2 diabetes, and then gestational diabetes means that this is the first time you've had diabetes that occurs for the first time during pregnancy. That's your gestational diabetes. All right, so more on this topic, okay? So gestational diabetes is the glucose intolerance for the first time during pregnancy. Two main categories, diet control and also insulin control. Abnormal glucose screening is going to be between 24 to 28 weeks. This is going to increase risk for the mother and the baby, okay? So some things that we do worry about, like I said, we're going to want to keep an eye on their blood sugar. Like I said, a glucose of 140 after a meal, that's not a big deal, okay? Because expected that your blood sugar is going to go up a little bit, okay? So some things that I want you guys to think about, okay? So because the thing is, you may have other issues along with this, okay? So, like we said, if you have a blood glucose of 140, 145 right after a meal, not a big deal, okay? And this is something I want you to think about, need to know. If you have trace amounts of protein in the urine, we may check it out, but like I told you guys earlier this week, is if you have trace amounts, we don't worry too much about that because you're going to have a little bit of trace amount of urine or glycosuria in the urine, but we still want to still check it out. Okay, fundal height measuring 38 weeks. Okay, if you have a fundal height measuring 38 weeks, depending on how pregnant you are, let's say you're maybe 35 weeks pregnant, that is a little bit higher. But like if you have something like persistent headache, blurred vision, epigastric pain, um, persistent headache, blurred vision. These are indications of preeclampsia, okay? So something like that is going to trump all of these other problems, okay? So I don't want you guys to just be like, okay, we have a higher blood sugar. This is what we need to focus on. Like I said, if it's a blood sugar of 140 after a meal, we don't worry too much about that. But like I said, if you have something like persistent headache, blurred vision, epigastric pain, dizziness, nausea, then that's going to lean more toward PIH, preeclampsia, and that's what we're going to want to focus on, okay? So that would be the emergency. So just, I want you guys to make sure that you're able to identify, you know, the issues, okay? Because like I said, persistent headache, blurred vision, nausea, vomiting, that's going to lean more towards preeclampsia, which we're going to get to later, okay? But I know a lot of students, okay, gestational diabetes, blood sugar 140. Ooh, no, like I said, especially if it's after a meal. So I just kind of want you guys to think about what the actual issue is, okay? That's what I'm trying to get you guys to think towards, okay? So like I said, let me know if you have any questions later, okay? All right, so let's go ahead and review our symptoms for hyperglycemia and also hypoglycemia. And these are need to knows because you are going to need to make sure you know your signs and symptoms. So let's go ahead and go over hyperglycemia first, okay? Are you guys still with me? Can we get a ooh, ooh? Well, that was still weak. And I know all of you guys, most of you guys probably didn't do it, but if you did, cool, okay? So hyperglycemia, we've got polyuria, polydipsia, blurred vision, polyphagia, frequent UTIs, excessive fatigue and hunger, recurrent vaginal candidiasis, sudden weight loss. Those are that's going to be your hyperglycemia. And like I said, I want to make sure you guys these are need to knows, okay? And then your hypoglycemia is going to be blood sugar less than 70, diaphoresis, tachycardia, shakiness, cold, clammy skin, blurred vision, extreme fatigue, mental confusion, irritability, and parla, okay? So you do want to make sure you know these things, okay? Because, you're probably going to be asked this, okay? So make sure you know your signs and symptoms for both hypoglycemia and hyperglycemia, okay? And your hyperglycemia, again, is polyuria. Remember what polyuria is? Okay, polydipsia, remember what that is? Blurred vision, polyphagia, frequent UTIs, excessive hunger, fatigue, recurrent vaginal candidiasis, sudden weight loss. Okay, that's your hyperglycemia. Again, hypoglycemia is going to be blood sugar less than 70, diaphoresis, tachycardia, shakiness, cold, clammy skin, blurred vision, extreme fatigue, mental confusion, irritability, and parla. So, and the thing that you do need to make sure you know your signs and symptoms, okay? So, like I said, let's say you have a patient who's saying that she is sweating more than she normally does. Her hands are shaking like tremors. She can't see clearly. What do you think this is going to suggest? Do you think it's hyperglycemia or hypoglycemia? And this is on page 180 in the book, okay? Page 180. So these are going to be signs of hypoglycemia. So this is why you have to know both so you don't mix them up, okay? And like I said, with the need to knows, I want you to know it, okay? Not just memorize it. I want you to know it so you can apply it. If you just memorize it and you can't apply it, that's not going to help you, okay? So these are need to know. Also make sure you see the risk for women, see risk for women and risk for fetal and newborn. Okay. So 179 in the book, we're going to talk some about your diabetes screening, gestational diabetes screening, okay? So this is also a need to know. I want you to have a good understanding of the gestational diabetes screening and glucose tolerance test. This is a need to know. Yes, you have to know it, okay? Yes, you have to know it all, okay? All right, so have a good understanding of this. So what this, and to the women out there who's had children, you guys know all about this, okay? So this is the oral glucose tolerance test. This test is typically performed between 24 to 28 weeks gestation to screen for gestational diabetes. So yes, you need to know what this is, okay? This is typically given 24 to 28 weeks of gestation to screen for gestational diabetes, okay? So, the 1 hour test is a two-step screening. The 1 hour test is non-fasting. They have to drink that lovely oral glucose. They have to drink it, and then we're going to draw the blood sugar at 1 hour. If the result is greater than 135, it's positive, and we must move on to do the 3 hours. So, if you have the 1 hour glucose tolerance test and it's below 135, that's considered normal. No further testing or dietary changes are needed at this time unless other risk factors are pregnant. So, or unless other risk factors are present. So, yes, you need to know this, okay? Now, let's say that if it was positive, we have to move on to the 3 hour. Okay, so the 3 hour one is this is fasting for 8 to 12 hours. You have to drink 100 grams of the oral glucose ingestion. I don't, does that stuff taste good? Let me know. You're going to have three different screenings, okay? You're going to have drawn at 1, 2, and 3 hours. If you have two or more blood draws above the threshold, then the diagnosis is positive. So you see the chart, okay? So if it's the first hour, fasting 95 or higher, the first hour, if it is 180 or higher, 2 hours, 155 or higher, 3 hours, 140 or higher. So you have to have with your 3 hour with the 3 hour one, if you have two or more blood draws above the threshold, then unfortunately you have it, okay? So, like I said, you do need to know this. So, the 3 hour test is only indicated if the result is 135 or higher for that first test. Okay, then we have to do the 3 hour one. So, like I said, fasting um, is going to should be 95. 1 hour is going to be 1 hour is going to be 190 or higher. 2 hours is 165 or higher, and 3 hours is 140 or higher. So the nurse needs to know the results and determine that the client has gestational diabetes. Okay, so you do need to make sure you know this. Okay, now on your PowerPoint, for my 3 hour, it looks like I have 180, but somewhere else, yeah, if it's 180 or higher, okay? So like let's say it's something like 195. Guess what? Okay, so I think I've confused myself and you, okay? So okay, so for the 3 hour fasting for 8 to 12 hours, you see the different readings on the PowerPoint. Go by that, okay? Go by that, okay? So I think I meant like if the 1 hour was 190 or 195, okay, then that's going to be higher than 180. If the 2 hour is 165 to 170, that's higher than the 155. Okay, and then if the 3 hour is 140, well, we've already got two that are higher above the threshold. Okay, so for the 3 hour, I want you guys to go by what I have on the PowerPoint, and if it's higher than this listing I have, then that's going to mean the higher than the threshold that I gave you, okay? I hope that makes sense, okay? So the nurse needs to review the results and determine that the client has gestational diabetes, like if it's high on 2 occasions. So what type of education should the nurse anticipate giving the client? Okay, well, this is still need to knows. If the results are higher, you're going to need to monitor the blood sugar at home and make dietary modification. And basically, this screening is going to be done for 24 to 28 weeks gestation. All women get screened for gestational diabetes because we want to catch it early. So, to the moms in here, do you guys remember having this done? How was it? How did the oral glucose taste? Was it yummy? All right. So, some nursing actions. You want to teach women to check their blood sugar, educate women on this, and to and to poorly educate women on this and to help control the diabetes, teach proper self-administration of insulin, teach women signs and symptoms of treatment, reinforce dietary management, reinforce the plan of care to self-management and fetal surveillance by prenatal care and daily kit counts. And what are the kit counts again? Basically, we want to remember kit counts. Remember how many kit counts should you have in 2 hours? No, in 1 hour. Sorry. So what are fetal kit counts again? What are they? And how many should you be having? And I'm not going to tell you because I told you in the last lecture, okay? So what are the fetal kit counts and how many should they have within 1 to 2 hours? I'm not going to tell you. That's something you have to go look up, okay? And also exercise as walking 10 to 15 minutes after each meal, okay? So like I said, these are some things that you need to be teaching them to do, okay? And like I said, those kit counts, I went over that last time. So what are they and how many should you have? I'm not telling. So if you don't know, go look that up, okay? All right. Now let's go ahead and move on to hypertensive disorders, okay? Now there's several different ones. Are you guys familiar with these? This is on page 181, okay? This is on page 181. Now, these are your different types: chronic chronic hypertension, gestational hypertension, preeclampsia, and eclampsia. Is anyone familiar with these disorders? Did anyone have these disorders during pregnancy or know anyone with these disorders? Now, the thing is, it is super easy to get these mixed up. These starts on page 181. Um, it's easy to get these mixed up. We're going to go through these, but try to think of ways to help differentiate this so you don't get them mixed up, okay? Because a lot of students get these mixed up, okay? Okay. All righty. So, are you guys still with me? Is everybody okay? All right. So these are your different types that you're going to see. Okay. So chronic hypertension. Let's start with this one first. And like I said, I want to make sure you guys have a good understanding. So you're going to have a systolic blood pressure 140 or greater. Um, Diastolic is 50 or greater. This is going to present and be observable before the onset of pregnancy. So if you have this before pregnancy, this is just your chronic hypertension, okay? Um, and basically diagnosed prior to 20 weeks, okay? Persistent past 12 weeks postpartum, okay? But this is something that you're going to have before that you were pregnant. Okay, we're on page 181 still. Okay, let's move on to gestational hypertension. So make sure you know this, okay? So you're going to have a systolic blood pressure of 140 or greater. Okay, diastolic of 90. Now with this is the first time you had hypertension during pregnancy after the first 20 weeks in a woman who normally doesn't have high blood pressure. So we're going to want to keep a close eye on the mom and baby. So like I said, this is need to know. So with this, a systolic of 140 or higher, protein on urinalysis. So you're going to see proteinuria, like it's not going to just be trace protein, it's going to be like +2 or so. Increased blood pressure readings, severe headaches, changes in fetal heart rate, chest pain. These are significant findings of potential complication, and things are getting worse with your gestational hypertension, okay? So severe headache, changes in fetal heart rate, increased blood pressure, chest pain. These are indication that things are getting worse with gestational hypertension. So you want to make sure that you know this, okay? All right. Okay, page 182 in the book. This is going to be your preeclampsia, and also be sure you see critical component on page 183, 184. Okay, so preeclampsia, PAH, is going to be with your severe features. You're going to have serum creatinine. It's going to be greater than 1.1, platelets higher than 100,000, elevated times 2 serum liver enzyme, new onset or cerebral or visual disturbances like blurred vision, persistent epigastric pain. So, some more need to know. If you preeclampsia, the combination of elevated blood pressure, proteinuria, visual disturbances, headaches, swelling of hands and face, we strongly suggest preeclampsia. This condition is typically occurs after your 20 weeks and it's characterized by hypertension protein seen in the client's lab results. Okay, so what you're going to see is proteinuria plus 2 plus and higher, blood pressure 155, 150 over 95 and higher. That can indicate potential diagnosis of preeclampsia. This is characterized by greater or equal to blood pressure 140 over 90, proteinuria greater than +1. That's going to be indicated in the client's lab, okay? So that's going to be preeclampsia, basically, is when you're going to have a whole lot more of these signs and symptoms, okay? So remember when I had said blurred vision, severe headache, pain, if you see these signs, if you see these, if the patient is complaining of this, this is indication of preeclampsia, okay? And we do worry because if the patient's blood pressure is getting higher, what's going to happen to the baby is going to lead to placental insufficiency. So the baby's placenta is not going to work as it should, and baby's not going to get what they need, okay? So you want to have a really good understanding of these different things, okay? All right, so we're on page 184 in the book, all right? So, with preeclampsia, this affects organ perfusion. So this is something that can really affect things negatively in the body, okay? Because it can affect perfusion, vasoperfusion, organ perfusion. And like I said, for the baby, what's going to happen is the placenta is not going to be working as it should, and it's going to cause placental insufficiency, so the baby's not going to get the nutrients that they need. So risk factors, what do you think some risk factors are for this? And like I said, in the book, it's on page 184. Okay, so we want to see nulliparity. What does nulliparity mean? If you don't know, I'm not telling. Go look it up. Maternal age, increased maternal age. What did I say increased maternal age is? Not telling you that either. If you don't know, look that up too. Pre-pregnancy obesity greater than 30, multiple gestation, chronic hypertension, kidney disease, systemic lupus, thrombophilia, diabetes prior to pregnancy, previous preeclampsia or eclampsia, gestational diabetes. With having gestational diabetes, you can also it's going to make you higher risk for preeclampsia. So that's why when I was giving you those signs and symptoms when we were talking about gestational diabetes, is because they can have preeclampsia with this. Assisted reproduction. Preeclampsia also causes vasospasm of the blood vessels. Women with a family history of hypertension are at higher risk. Being overweight can also increase the chances of developing preeclampsia. Multiple gestation can also increase the risk of preeclampsia. Women with a history of preeclampsia are increased risk for future pregnancy. Okay, so the thing is, I want you to make sure that you know these things, okay? So, like I said, I've been saying this was neat to know. So, all of this stuff is neat to know. So, you want to make sure you know your risk factors, like we had said earlier. Increased maternal age. Like I said, if you don't know that, make sure you look that up. Obesity, high BMI, multiple gestation, like all the things I just said, all of that's neat to know, okay? So make sure you know all of these things that can be risk factors like multiple gestation, you know, um, also, like we said, preeclampsia causes vasospasm. Women with a family history of hypertension are at higher risk. Overweight, can be a risk factor for preeclampsia. Multiple gestation, if you have a history of it. And then here's a review from last week. What are issues obesity can cause in pregnancy? Then this is from last week. What are issues obesity can cause in pregnant women and increased BMI? We went over this last week. This is a review, and I'm not going to tell you. So if you don't know, go look it up. All right. So make sure you go review issues in obesity that can cause pregnant women. Okay. Review what are issues obesity can cause in pregnant women with increased BMI. I'm not going to tell you if you don't know. Go look it up. That's going to be something you need to know. Okay. All right. Medical management. So medical management, okay? And this is still need to know, okay? So make sure, you're paying close attention, okay? And if you missed something I said that was need to know, make sure you go back and listen, okay? Because that's the cool thing about this. You can go back and listen to it, okay? All right, so this is on page 185 in the book, medical management. So make sure you know this for preeclampsia. So in this case, remember we said mag sulfate was used for preterm delivery. For preterm labor, we give that for neuroprotection to help decrease the risk of cerebral palsy and to help suppress contractions. In this case, we give magnesium sulfate to reduce seizures due to increased blood pressure. So, like I had said earlier, we give magnesium sulfate for preterm labor for fetal neuroprotection. This is going to help to decrease cerebral palsy, and it's used as a muscle relaxer. This helps to decrease seizure activity. Make sure you know that. Do not mix up these meds, okay? Okay, labetalol, because we do give antihypertensive meds. This is still neat to know. Labetalol is an antihypertensive med commonly used to manage hypertension during pregnancy. It's effective, safe for both the mom and the baby. Hydralazine, this is used for cases of severe preeclampsia. The primary goal is to manage hypertension and prevent complications such as stroke or seizures. Their clients, so if they have a high blood pressure, the nurse is going to want to give hydralazine or a antihypertensive agent. Like we said, magnesium sulfate is going to be used for to help prevent seizures, okay? So, like we said, make sure you know your medication, and make sure with these patients, we're going to want to be assessing the baby, weekly antepartum testing, closely monitor blood pressure. We'll have them monitor their blood pressure at home as well. Weekly labs for preeclampsia, like liver enzymes. All right. Are you guys still with me? I know this is a lot, okay? So what are we going to do? What are some things we're going to want to make sure we do for women who are hospitalized for preeclampsia? Okay, so when we assess the blood pressure, you need to use the correct size cuff. If you use a blood pressure cuff too small, that's going to cause elevated blood pressure, which is more stress, which we don't need that, okay? We want to assess for CNS changes, okay? Like central nervous system changes. You want to assess frequently for this, okay? You want to keep asking these questions because the signs can get worse if preeclampsia is getting worse. So let's go over those signs again, okay? And these are need to knows. Headache, visual changes like blurred vision, deep tending reflexes. Deep tending reflexes are going to be hyperreflexia, okay? So instead, it'll probably be like a +3 or +4. Hyperreflexia, clonus. So clonus is you take the person's foot and then you bend it back slightly. If nothing happens, that's negative for clonus. If you bend the person's foot and then it taps your hand, that's +1. If you bend it back and the foot taps your hand twice, that's +2. Okay, clonus means impending seizure, okay? I meant to show you on the mannequin, but when I was trying to do bubbly on the mannequin didn't have any feet, okay? But anyway, that's clonus, okay? You also want to ask about epigastric pain. And epigastric pain is also closer to chest pain, so we may ask about chest pain. Okay. So like I said, need to know. Make sure you know your signs and symptoms of your preeclampsia. Okay. You want to listen to the lungs, for wet lung sounds and pulmonary edema. It epigastric pain. Daily weight. Check for protein in the urine. You want to monitor I's and O's. Why do you think we want to provide a quiet environment? Because if it's quiet, that's going to be less stressful opposed to if there's all sorts of bells and things going off. Why would we want to put them sideline? Laying on the left side is best because that's going to take pressure off of the vena cava. We will also want to make sure that we check labs such as elevated liver enzyme, AST, ALT, blood levels. You want to assess for epigastric pain or right upper quadrant pain, assess for fetal assessment, fetal movement. If mom reports decreased fetal movements, this should be investigated. Biophysical profile, that was actually one of those diagnostic tests that we were going over. I'm going to go back over those on Tuesday for you, but that's going to test for fetal hypoxia. We want to symptoms such as severe headaches are classic signs of preeclampsia because that can indicate cerebral edema, hypertension, epigastric pain. A lot of these things can suggest liver involvement. Changes in vision can lead to severe hypertension or complications like retinal detachment. Right upper quadrant pain may also occur with hepatic involvement in preeclampsia and liver and signal liver distress. Increased deep tending reflexes can be a sign of neurological involvement due to hypertension. So you're going to see increased deep tendon reflexes. And like I said, all of this is need to know. So hopefully you're taking all of this, okay? Increased deep tendon reflexes, nausea and vomiting and visual disturbances and swelling in the hands and face. So be sure that you know your priority findings. Be sure to figure out which patient is going to need care first. Client reporting sudden onset of blurred vision, upper abdominal pain, proteinuria +2 or higher, increased blood pressure. So, like I said, make sure you know all these things, okay? And make sure you know your nursing actions. You want to monitor vital signs, baby's heart rate, assess for signs of bleeding and bruising, because that's petechiae, that could, indicate issues later. You want to administer mag sulfate if ordered. What did we say mag sulfate was? That's to help prevent seizure. Obtain lab tests to assess liver function and platelet count. We want to place the client on the left side. That's going to help with oxygenation. We want to give antihypertensive that are prescribed, assess deep tendon reflexes, check for clonus, monitor intake and output, give mag sulfate as prescribed, and make sure you know patient teaching, okay? So make sure the patient knows when to call the doctor. So make sure the patient knows that they need to report any sudden swelling of their hands, feet, and face. If they have persistent headaches or blurred vision or seeing spots, that's not normal. We need to report that to the doctor. The patient needs to monitor blood pressure and report anything above 140/90. The patient needs to know they need to rest on their left side. If they start to feel dizzy or lightheaded, weight gain of more than 5 pounds in a week, they need to report that as well. So this is a lot of information, okay? A lot of information. You may not have got it all the first time, so go back and listen, okay? Okay, this is on page 186 to 187. So we're going to talk about mag sulfate, okay? So what did we say mag sulfate was? Okay, quick review. What do we give mag sulfate for preterm? I've said it several times, okay? Fetal neuroprotection, okay? So they can have a decreased risk of cerebral palsy, and also to help suppress the contraction. So for this, for preterm labor, no, for just for the preeclampsia, this is given because we want to make sure that we decrease the risk of seizures, okay? This medication is highly potent. We have to monitor hourly. We check vital signs. We usually have them connected to a heart monitor with a blood pressure cuff connected. We ask about headache, visual changes. We check their deep tendon reflexes. Clonus, that's when you assess the foot. Like I said, for clonus, you push the foot back gently. If nothing happens, it's fine. If you push the foot back and the foot taps your hand, that's +1. If you push it back, tap, tap, that's +2, that's clonus, okay? That's something you need to assess. Epigastric pain, ask about epigastric pain. We listen to lungs for wet lung sounds, monitor I's and O's. We make sure that the dose and everything is set correctly. So the dose is going to be listed here. Okay, what is that? What is it going to be the antidote? You want to make sure you know the antidote. Calcium gluconate. The when if we give this if the patient is becoming if they're having mag toxicity. So you're going to know if they have mag toxicity if they have decreased respiratory rate, diminished deep tendon reflexes, because remember we said the deep tendon reflexes need to be are going to be hyperreflexia. Now they're going to be diminished. That could indicate mag toxicity. So you want to make sure that you have the calcium gluconate on hand. So you want to be familiar with what MAC sulfate's for, the calcium, the antidote, which is calcium gluconate. And you also want to make sure that you know, this is also a need to know, that preeclampsia causes vasospasms of the blood vessels. Clients with diabetes or pregnant with twins are higher risk for developing preeclampsia, headache, blurred vision, epigastric pain, or symptoms of preeclampsia. Megsulfate is used for preeclampsia, and preeclampsia is typically done in the first trimester. So make sure you know that. And make sure you know why we give the calcium gluconate if the patient has mag toxicity, such as decreased respiration rate, diminished deep tendon reflexes. This is going to indicate mag toxicity. Calcium gluconate is an antidote for mag toxicity. So make sure you know why we give mag sulfate. Make sure you know signs and symptoms we're looking for. Make sure you know what calcium gluconate's for. Anything I said need to know is need to know, okay? And if you didn't get it, go back and listen, okay? Okay, so now we're on page 187, okay? So I've already kind of went over the stuff for mag toxicity. With mag toxicity, and like I said, this is on page 187. With mag toxicity, the patient will be lethargic. So if you suspect mag toxicity, you need to stop the infusion. So it's sort of like a drug, it's sort of like a blood transfusion. If you notice a reaction, you stop the blood and give normal saline and call the doctor. With this, go ahead and stop the max. Go ahead and stop the mag if your patient is going toxic, and and give the antidote and call the doctor, because if you call the doctor while the patient is going toxic and you don't stop it, then you're going to be responsible that you did because you didn't stop it. Because if you can see the patient is going toxic, you need to go ahead and stop it and let the doctor know. Don't just let it keep going. Don't just, hey, hi doctor. Don't call the doctor and be like, hi doctor, I think the patient's toxic, should I stop the mag? The doctor's going to scream at you. It's like, well, if you think the patient is toxic, you should have stopped it already, because like I said, it's like a blood transfusion. If a patient is having reactions, you would go ahead and stop it. You wouldn't just call the doctor, hi, the patient's having reactions to the blood. Do you want me to stop it? No, you need to go ahead and stop it, okay? So these are some things to assess for with mag toxicity. Like I said, decreased blood pressure, decreased urine output, decreased respers, decreased DTRs. Like we said, stop the magnesium, give the antidote because it should already be ordered, and let the doctor know immediately, okay? All right. Now, this is going to be emergent therapy for severe hypertension, okay? So this is going to be on page 189 in the book if you're following along. So these meds are given for increased blood pressure, okay? Now, what did we say nifedipine was given for earlier for preterm labor? For preterm labor, nifedipine is going to be given. It's a muscle relaxer. It's going to decrease your contractions. Now, for PIH, preeclampsia, we give this med for increased blood pressure. This is why I'm stressing, do not mix these meds up. They're used interchangeably. See table 7-4, page 186. Um, you see that table, okay? That's going to be some good information. That's the meds for preeclampsia and eclampsia. So be sure that you know your medications for this and do not mix them up. We went over labetalol earlier, labetalol, hydralazine. These are all going to be your medications for increased blood pressure. And we're going to be monitoring the blood pressure thoroughly. So there's a chart on page 189 that's going to have your meds on them. But like I said, these are going to be your blood pressure medications. So we want to give this to help bring down the patient's blood pressure, okay? Okay, and then we're also going to want to assess for cerebral irritation. So, like we said earlier, headache, visual changes, hyperreflexia, deep tendon reflexes, clonus, all of these are signs that basically the PIH is getting worse and it's starting to affect their nervous system. Okay, so these are need to knows: headache, visual changes, DTRs, clonus. And remember, I told you how to assess for clonus. I didn't get a chance to show you this in the lab because when we were doing our bubble lead, the patient didn't have any legs, okay? So again, to assess for clonus, you dorsiflect the woman's foot. If the foot taps your hand, that's going to be clonus, okay? If nothing happens, then clonus is negative. Clonus means severe PAH, and it also means impending seizure. So these are neurological issues. This is why we're asking the patient, do you have headache pain? Do you have blurred vision, etc.? It's because of this, okay? And we want to make sure that we know what the patient needs to report, okay? I think I said this earlier. We're going to say it again, okay? These is need to know of things that patients need to report. The patient needs to know to report any sudden swelling of the hands, feet, or face. If they experience persistent headache, they should contact the doctor. Blurry vision or seeing spots is an abnormal part of pregnancy, needs to be reported. It's important that they monitor their blood pressure and report anything above 140/90. They need to rest on their left side if they start to feel dizzy or lightheaded. Weight gain of more than 5 pounds is a sign that they need to report. So make sure we know things that we need to report and basically signs of issues for PIH. Okay, next is eclampsia. And like I said, I know that this is a lot of information, okay? And the nice thing about with the recording is you can stop it at any time, okay? So if you need to stop it, go use the bathroom, go get a snack, just take a break and come back to it later, that's perfectly fine, okay? So this is on page 189 in the book, and box 7-4 is an eclampsia protocol, okay? Of what we should do. So has anybody heard of this? It's called eclampsia. This is basically a preeclampsia with seizures. Are seizures ever a good thing? If you said yes, you're wrong and canceled. Seizures are never a good thing, okay? This is why when pregnant women have high blood pressure, we take it serious due to various complications that can occur with this. So, like I said, um, this is your high blood pressures with seizures, and this can occur at any time. So we want to keep a close eye on this. Okay. So we also want to make sure we get the patient ready for a possible seizure, okay? So what are some things we can do to care for a patient during a seizure, okay? So these are some need to know, so make sure you know your care for a patient during seizure. You want to stay with the patient, call for help, ensure patient safety. Like I said, need to know. Okay, first of all, airway, breathing, circulation. We want to assess airway and breathing. We want to lower the head of bed, turn patient to the side, keep side rails up and padded, suction airway as needed, record time, length, and type of seizure. Also give mag sulfate for the high blood pressure if ordered. They need to be in bed rest in the left lateral position. Give antihypertensive meds, assess deep tendon reflex, clonus, monitor I's and O's, and administer magnesium if prescribed. These are all appropriate interventions. So make sure care for a patient during a seizure, okay? And if you didn't get all of this, make sure you go back and re-listen to it, okay? We got this. Remember what was my inspirational saying of the week? It was stay dedicated, okay? Okay. Now, care after a seizure. So, why would we want to continue to assess the mom and baby? Well, see, the thing is, we want to make sure the baby's doing okay. So we may see bradycardia. Okay, bradycardia is low blood pressure. Also, decreased variability. Now, we're going to talk about variability when we get to intrapartum care because then we're going to talk about how to monitor the strep. But decreased variability, the fetal heart rate. This refers to fluctuation in the heart rate from beat to beat. Decreased variability or minimal variability can be a sign of fetal distress, often due to hypoxia or medications affecting the fetal central nervous system. So we're going to want to continue to monitor both the mom and baby, keep assessing the airway suction if we need to, give supplemental O2, ensure that they have a good IV access, and we want to make sure we keep it nice and quiet because we don't want that blood pressure to go up and cause all these problems again. Okay, page not 190, page 190. So this is HELP syndrome. You guys, has anybody heard of this? So this helps you to understand what this is and the issues that it can cause. Okay, this is associated with maternal morbidity and mortality. So, and also, I have heard women, they can lose the baby from this. Okay. So you want to make sure you know this acronym. H is for hemolysis, E is for elevated, L is for liver enzyme, L is for low, P is for platelet. So HELP syndrome is a severe form of preeclampsia. So you do want to make sure you know the acronym, okay? Because that'll help you understand it. Okay, so you want to be sure you know your labs for this, okay? Make sure you know your labs. But the cool thing is you're going to have a chart and it's going to have the different ranges, okay? So be sure you know your labs. This can be very dangerous for mom and baby because both mom and baby can die. The baby can die, okay? So you know, the thing is, make sure you know this diagnosis, okay? So you're going to want to make sure you know this slide definitely, okay? LDH is an enzyme involved in energy production. It's found in almost every cell and organ of the body, including the liver, okay? So make sure you know your normals and make sure you know what you may see with this, okay? So AST of 70 or greater, that's a no-go. Um, yeah, and sorry, an AST of 70 or greater is a no-go. Okay, if you have high ALT, that's going to be a no-go as well. Um, if you may end up having platelet counts. If you have like your platelet counts, or and also bilirubin, your bilirubin should be zero point 0.2 or bilirubin. So, if bilirubin 0.2 or greater, that's a no-go. So the thing is, make sure you end up knowing what you would see for this, okay? So make sure you know the diagnosis for this and any labs that are out of whack, okay? And make sure you know what HELP syndrome is. So need to know. HELP syndrome is characterized by hemolysis, elevated liver enzymes, low platelet count. Hypertension is commonly present as it is associated with severe preeclampsia, which can progress to HELP syndrome. Proteinuria may occur, but is it not diagnostic criteria for HELP syndrome? So make sure you know this information. Okay, assessment findings. This is on page 190 to 193. So, assessment findings are related to alterations in laboratory tests associated with changes in liver functions and platelets. These are things we're going to see. So, this is neat to know, okay? So, the symptoms suggested preeclampsia with possible HELP syndrome, right upper quadrant pain, hypertension, proteinuria. So, we're going to make sure we monitor vital signs and fetal heart rate, assess for bleeding, administer mag sulfate if ordered, obtain lab tests to evaluate liver function, and platelet counts or appropriate interventions. So you want to make sure that you know your signs and symptoms of your health findings, okay? Make sure you know this as well, okay? And this was page 190 to 190 to 191, okay? Okay, medical management for this, okay? So in these cases, we have to deliver the baby so we can focus on mom or both mom and baby could die, okay? So we need to go ahead and get the baby out, get out the baby in the placenta. Then we need to see improvements in signs and symptoms after the delivery. We may have to give platelet replacements because they're going to have lower platelets with this. Okay, so this is on page 191. So what do you think we should do in terms of nursing actions for this? So we want to perform thorough assessments, we want to evaluate labs, we want to let the doctor know immediately if HELP syndromes are suspected or lab values deteriorate, administer platelets per orders, assessment of management are the same as preeclampsia. So these are things that we want to do to kind of help out what we're going to want to do for the patient. All right. So I know that was a lot of information, okay? A lot of information. So, like I said, if you need to take a break, if you need to go get a snack, this would be a good time because now we're going to go to placental and hemorrhagic problems, okay? All right, and I hope this is all coming through. I really do. But like I said, if you have questions, make sure you write them down so that way you can reach out to me or we can go over them on Tuesday, okay? All right. So now let's talk about placental issues. This is going to start on page 191. So what do you think this is? Has anybody heard of these things? Um, so basically, your placental issues is going to be a lot of issues with bleeding. We want to make sure we assess the baby, fetal condition, prompt resuscitation, because with losing a lot of blood, you're going to be having a lot of problems, okay? And we may have to go ahead and get the baby out. So, major blood loss during pregnancy is a significant contribution to both maternal and fetal mortality and morbidity. Hemorrhage predisposes a woman to hypovolemia, anemia, infection, and premature birth and maternal death. Yeah, so hemorrhage can predispose a woman to hypovolemia, anemia, infection, premature birth, and premature death, and maternal death, sorry. So these are going to be your different disorders like placenta previa, placenta accreta. These are placental disorders associated with bleeding in the second half of pregnancy. Okay, so on page 192, okay? So let's talk about this. So vaginal bleeding criteria. So sterile vaginal exam is contraindicated in all pregnant women with extensive vaginal bleeding until the source of bleeding is identified. So why do you think we want to avoid sterile vaginal exam? Why would we want to avoid sterile vaginal exams? Okay, because this could cause additional damage and more bleeding, and this is a need to know, okay? So the thing is, if we have a woman who's having bleeding issues, we need to avoid vaginal exams, and that's putting your fingers up there to check to see how far they are. We don't want to do any sterile vaginal exams or using the speculum. We don't want to do that until we know the source of bleeding, okay? So this needs to be avoided because this can cause additional damage and more bleeding. So make sure you know that, okay? All right, so now let's go ahead and go to page 192. Okay, so this is placenta previa, okay? Placenta previa. So basically, this is the placenta is blocking the door of the cervix because you can see in the picture, you see how the placenta is blocking the door. The baby can't come out, okay? So the placenta is blocking the door of the cervix and the baby is unable to come through the cervix. So this can also cause more bleeding and complications, okay? And these are terms you're going to want to make sure you know so you don't mix them up, okay? So on page 192, some different risk factors: endometrial scarring, previous placenta previa if you have a history, prior C-section birth, abortion involving suction cartilage. So all of these can cause a risk factor for placenta previa. Okay. So what did we say placenta previa was? It's basically when the placenta is blocking the door of the cervix and the baby can't come out. So I want to make sure you have an understanding of what it is. Because like I said, I can give you need to knows, but if you don't know what it is, it's not going to help because you can't really identify what we're talking about, okay? So some of the different risk factors, hemorrhagic or hypovolemic shock, excessive blood loss, um, hysterectomy, ICU admission. You can have septicemia, maternal death, thrombophlebitis, RH sensitive, if RH negative, profound bleeding. Okay, so make sure you know what can cause this and make sure you know what you'll see. You're going to see a lot of bleeding with this as well. Okay, so make sure you know some complications such as hemorrhage, profound bleeding. Okay. Complications to the baby, okay? Anoxia. Anoxia occurs when there is no oxygen supply reaching the organ tissue. Organs need oxygen to survive, and it could cause brain death for the baby, okay? Fetal anemia, death, blood loss, progressive deterioration of the fetal status, all right? Okay, and like I was saying, what I want you guys to know for this is make sure you know what it is and what can cause it, okay? Make sure you know your signs and symptoms as well. So on page one, on 193, make sure you know your assessment findings. So like I said, for the need to know for this, make sure you know what this is and make sure you know what you're going to see with this, okay? So you want to make sure you know your assessment findings for this, okay? You're going to see low blood pressure, because this is the thing about with hemorrhage, you're going to see the low blood pressure and increased heart rate because the body's trying to compensate. So you're going to see low blood pressure, painless bright red vaginal bleeding, no contractions or abdominal pain. So with this, you're going to have low blood pressure, painless bright red vaginal bleeding, no contractions or abdominal pain. With placenta previa, even if you have light spotting, you need to contact the doctor for further guidance, okay? An ultrasound can confirm placenta location. Mom's going to have fear and anxiety. And also, non-reactive fetal tones. Non-reactive fetal tones, is that good or bad? It's bad. We want them to be reactive. So non-reactive fetal tones on the heart tones can further indicate potential compromise in fetal well-being because this is going to affect the baby as well. Um, so you want to take a look at the vital signs. If mom has low blood pressure and tachycardia, like any tachycardia is anything over 100 and over 100, that means that the body's trying to compensate. No pain, then you can suspect that it's possibly placenta previa, okay? And we're going to need further evaluation. And like we said, vaginal examinations are contraindicated. It can result in profound bleeding, okay? So make sure you got all of that. Make sure you know what you're going to see for that, okay? If you have questions, I got you, okay? But make sure you know this, all right? This is your need to know. Placenta previa assessment findings. Make sure you know this, okay? All right. Now we're going to be on page 193, okay? So, what is medical management for this, okay? We're going to need to do a C-section. Why would we need to do a C-section? First of all, what is placenta previa? It's when the placenta is blocking the door. Baby can't come out the vagina, so we're going to need a C-section, okay? And then also, so we're going to want to do C-section if in labor or if bleeding results in unstable. This is going to increase the risk for postpartum hemorrhage. We may need a blood transfusion. Why would we need a blood transfusion? Because due to blood loss, the woman can't deliver vaginally because it's too dangerous and they're losing a lot of blood, so they're going to need a blood transfusion for this. And this is page 193. Okay, expectant management. Expectant management. Now, this is performed if the mom and baby are stable. Okay, so if the mom and baby are stable, we don't need to deliver. Okay, we want to try to prolong pregnancy, especially if the baby's premature. We're just going to need close observation. So, expectant management. This is performed when the baby's premature to allow the baby's fetal lungs to mature. The benefits of a planned delivery under optimal circumstances and before labor or bleeding must be weighed against the risk of prematurity, okay? Because like I said, if they're not stable, if they're bleeding a lot, we may have to go ahead and get the baby out. But if they're doing okay, if both mom and baby are stable, they can stay pregnant. This typically includes close observation and hospitalization. If the woman and fetus remain stable and the bleeding stops, we can discharge them home. benefits of bed rest, pelvic rest, reduced activity remain, so we definitely, another need to know, we want to make sure we teach them to avoid any activities that may put strain on the abdomen, and we want to make sure that they're trying to get rest, okay? So a need to know is avoid any activities that may put strain on the mom's abdomen, okay? Because that can cause bleeding again. Okay, nursing actions. This is on page 193 in the book, okay? So for nursing actions, we want to make sure that um, and that we want to assess abdominal pain, which they may not, they probably won't have, they may have uterine tenderness, but this is typically painless. They may have irritability, contractions. We want to initiate bed rest with bathroom privilege, establish IV access with large bore needle in case we have to give blood, give O2 if needed, assess fetal heart rate, give corticosteroids to accelerate lung maturity, activate transfusion protocol if they've lost a lot of blood, and some more need to knows for you guys. Avoid any activities that could put strain on the abdomen because clients with placenta previous should avoid activities that can cause increased uterine activity or bleeding, such as heavy lifting or strenuous exercise. This guidance is essential in maintaining the client's safety and preventing complications related to her condition. We also want to make sure we teach her to contact healthcare provider immediately for further guidance, like if they have light spotting, because that's going to require evaluation by the doctor. It could also indicate a change in condition that could lead to significant complication. So we want to make sure we teach the patient to report any bleeding because we want to ensure the care of both mom and baby. So you want to make sure you know nursing actions and information that you want to make sure you teach the patient, okay? All right, next we're going to talk about placental abruption. Placental abruption is on page 194. So this is bleeding at the placental interface. It can cause partial or complete placental detachment prior to delivery of the fetus. This is initiated by hemorrhage. So I want to make sure you guys know your signs and symptoms and know what this is because, like I said, it doesn't do you any good if you don't know what it is. So this is basically detachment of the placenta from the uterine wall, okay? So that you're going to see a lot of bleeding. So need to know, you want to know signs and symptoms of this. So if the patient is reporting sudden onset of severe abdominal pain, dark red vaginal bleeding, okay? So make sure you know your signs and symptoms of this and know what it is, okay? So if you see a sudden onset of severe abdominal pain and dark red vaginal bleeding, then this we want to evaluate for this. And this is page 194 if you're following along with me. Okay, so what are some causes of this? How does this happen? Okay, so I want to make sure you know risk factors for this as well, okay? So risk factors. Um, we got previous abruption, hypertension, prior C-section, maternal age, multiple gestation, also uterine fibroids, abdominal trauma, like a motor vehicle accident, like a car accident can cause this to happen, cocaine, methamphetamine, cigarette, or smoking. So like we said, such as a head-on collision, like a car accident, there's an increased risk of placental abruption, where the placenta detaches from the uterine wall, leading to potential maternal and fetal complication. This condition can result in vaginal bleeding or abdominal pain and fetal distress. So I want you to know what causes this, okay? So this is all need to know, okay? Okay. So still on page 194, I believe, on page 194. So, risk factors. So what are some risk factors we would see for this? So risk factors is hemorrhage, the need for blood transfusion, emergency hysterectomy. And I've seen where, if a woman couldn't start bleeding, they just had to go ahead and take out the uterus. DIC, disseminated intravascular coagulation. That's a blood clotting disorder where no matter what, the patient can't clot, so patient bleeds out. Renal failure, maternal death. So these are risk factors that can cause this or whatever. This puts a woman at risk for this as well. Okay, so this next slide is going to be graphic, okay? So I just want to warn you, trigger warning, okay? So this next slide is a trigger warning. Okay, so on page 195, so this is some risk to the baby. Risk to the baby. Low birth weight, preterm delivery, asphyxia, stillbirth, perinatal death. So this could lead to death, basically. So I'm sorry about the slide, but this could lead to death because the baby's not able to get what they need. So they're not going to get oxygenation to the brain because we're losing all this blood. Okay, on page 195, we're going to talk some about the diagnosis for this, okay? So, diagnosis diagnosis is made on the woman's history and clinical presentation, physical examination, lab values. Mom may also have fear and anxiety, okay? Lots of signs and symptoms, okay? So make sure you know your assessment, okay? Make sure you know your assessment, need to know for assessment, okay? So lots of signs and symptoms will be a result of hypovolemic shock due to blood loss. So leading to severe abdominal pain, dark red vaginal bleeding, sudden onset of these symptoms in the third trimester suggest critical situations that require immediate evaluation and intervention to ensure the safety of both the client and the fetus, okay? So make sure you know what you're looking for on assessment, okay? And then also the fetal assessment. The fetal assessment, that is going to be your fetal strips, basically, So, like I said, you could see tachycardia, bradycardia, and we're going to talk more about the strips when we get to intrapartum. But, like I said, if we see a decreasing fetal heart rate baseline, then that's bad, okay? But make sure for the mom, you definitely know, your signs and symptoms of this, okay? Okay, on page 195, okay, on page 195. This is a medical emergency, okay? So, due to so much blood loss, we have to try to restore the blood loss and the blood volume. So, we want to monitor blood volume status, monitor coagulation, restore blood loss by giving blood transfusion, assess fetal status, and then also if we need to go ahead and deliver the baby, we deliver the baby because, like I said, safety and health is the first priority. Okay. So next we're going to look at, hospitalization. So why do you think we would need hospitalization for this, okay? If the maternal status is stable, but fetus is immature, we're going to want to, continue to hospitalize and give corticosteroids. So why do you think we want to give corticosteroids? We talked about this earlier, okay? So corticosteroids, this is given to accelerate fetal lung maturity in case we have to go ahead and deliver the baby, okay? Um, so current recommendations we want to try to deliver at 36 to 37 weeks gestation for stable women without bleeding or complications. So we hope that we can keep you pregnant. If not, then we'll need to go ahead and deliver, but like if they're stable, we try to keep you pregnant. But like I said, if we have to go ahead and deliver the baby, we typically hope we can deliver at 36 to 37 weeks gestation for stable women without bleeding or other problems, but we may not be able to do that. But like I said, if we're unable to, then we'll go ahead and deliver the baby, but we want to go ahead and give corticosteroids to help accelerate fetal lung maturity for the baby. Okay? All right, we're still on page 195. Okay, so nursing actions. So we're going to look at some nursing actions that we're going to want to do, okay? We want to do close monitoring, palpate the uterus. We're going to palpate and assess the uterus for contractions and tenderness, hypertonus, or increasing uterine distension. Okay, why would we want to monitor fetal heart rate? We want to monitor the fetal heart rate because we want to make sure the baby's doing okay. We want to make sure the baby is tolerating this, okay? And the only way we're going to see that is by assessing the fetal heart rate, assessing the fetal heart tones, looking at the strips. We want to make sure mom has a good IV access. Why would we want to do that? Because we want to make sure we can give blood if we need to, and also IV fluids because, for dehydration. We want to give oxygenation. The thing about when you're bleeding a lot, blood carries oxygen. And so when you're losing blood, you're losing oxygenation. So we may need to go ahead and give oxygenation. We want to monitor I's and O's. We want to give good, provide emotional support because, of course, mom's going to be scared. We may need to activate massive transfusion protocol as needed because they may need blood. This is why we want to make sure they have a good IV access, anticipate C-section, administer RhoGAM if needed, if mom's O negative, give corticosteroids if baby's premature. What did we say corticosteroids are? We just said it on the last slide. So if you don't know, go look it up, all right? Okay, now we're going to be on page 195 to 196, okay? This is the placental accreta. So, like I said, I do not want you to mix these things up. Do not mix these up. This is why you want to know what they are because it's easy to mix all these up because they all start with placenta. So placenta accreta is a term used to describe the clinical condition where part of the placenta attaches or the entire placenta attaches to the uterine and the placenta becomes inseparable. So this is when the placenta is attached to the uterine wall and it will not come off. That's bad because when the baby delivers, the placenta has to deliver. But if it's stuck to the wall, this is going to be a problem during delivery because the placenta is not going to completely separate from the uterus. And this is followed by massive hemorrhage leading to DIC, disseminated intravascular coagulation. We may need to go in and do a hysterectomy to surgically scrape the placenta off, surgical injury by the uterus, bladder, or bowel, as well as other issues. So, need to know for this, okay? You want to make sure you know what this is. So, placenta accreta occurs when the placenta attaches too deeply into the uterine wall and does not separate properly after delivery. It does not resolve on its own, and it usually requires a planned C-section delivery. Patients may be at higher risk for hemorrhage during delivery, sometimes followed by a hysterectomy to control the bleeding. Still need to know the ultrasound report indicates an abnormally in placenta that is invaded into the uterine wall. So this condition is particularly associated with previous C-section delivery and poses a high risk of severe hemorrhage during the delivery. Patients may experience severe bleeding during the delivery. And on the slide, you can see the different types of accretas. This is like the different degree that it is attached, okay? So basically you have your normal attachment, then the accreta is when it's starting to attach to the wall. Look at the slide picture. You see how the accreta is going into the uterine wall, okay? And then the increta is going further into the uterine wall, and the precreta is all the way in, okay? The precreta is not going anywhere, okay? So you're gonna, like I said, when you get to the accreta state, it's not going to separate it on its own because you're going to have some attachment to the uterine wall, but then after you have the baby, the placenta is going to detach and deliver. But with your accretas, the placenta is deeply attached to the wall and it's not going to come out. So we'll need to do surgery. Okay, I know this is a lot of information, you guys, so stay with me, bear with me, okay? So now let's talk some about medical management for this, okay? So medical management um, for this is going to be, and we're going to still be we're on page 196 or 197, okay? So the timing of this is usually going to be 34 to 37 weeks gestation, and we're typically going to have to do a C-section with a planned hysterectomy. It's really hard to preserve the uterine because, like I said, you're going to have to go in and scrape the placenta off, and this can be life-threatening. So let's think about what we want to do for the baby. So for preterm delivery, we're going to want to give corticosteroids. For this, I want to make sure that need to know possible treatment, okay? So potential complication is going to be accreta can lead to severe hemorrhage during or after delivery. In such cases, we'll need a hysterectomy, may be necessary to control the bleeding and ensure safety of the client. So the patient's going to have an understanding that they may have to have a C-section definitely, because this is not going to be able to be vaginal, and also a hysterectomy. So make sure that you know complications and make sure you know treatment for this, all right? Okay, some of the complications for this. So increased risk for infection, thromboembolism, pyelonephritis, pneumonia, adult respiratory distress syndrome, renal failure, and need to know, make sure that the patients have a good understanding that they're going to have severe bleeding during delivery and that they're going to understand the different risks associated with placenta accreta, such as significant hemorrhage, during or after delivery, and surgical treatment, loss of future fertility, and injury to the other pelvic organs. Because if we have to do the hysterectomy, then they won't be able to get pregnant anymore. So make sure they have an understanding of that. Because, like I said, in labor and we're having this happen, that's not the time to be like, okay, let's go over the treatment. No, we need to go ahead. They need to have an understanding of this now, okay? So they're probably going to have hypovolemic shock, which that can happen because we've lost so much blood, then your body goes into shock. ICU and surgical treatment for this, okay? So make sure that the patient understands what this is, that they're going to have severe bleeding, and they may need to have a hysterectomy, and they have an understanding of why this is happening. Okay, page 197. So, nursing actions. So why would we need to maintain a large bore IV access? Why do you think that is? Okay. So the thing is, we may be having to give blood because they're going to lose a lot of blood for this. So you got to have a large bore IV access, okay? We're going to want to cross match, type and cross the blood. We're going to want to type and screen the blood type. We want to hold 4 units of pat red blood cells, monitor lab CBC and clotting factors, activate massive transfusion, okay? So these are all the things we're going to want to do for nursing actions. And this is neat to know because we need to talk some about religion and spiritual, okay? So how do we evaluate cultural and spiritual needs, okay? So this is neat to know with high risk pregnancy. So example, let's say we have a patient of Jewish faith. How would you evaluate that? You would just simply ask, can you tell me how your religion impacts your pregnancy choices, okay? Because we need to know so that way we can try to incorporate that in the plan of care. So need to know for high risk pregnancy about religious and spiritual um things that they want to do. You would just ask, so how would you, how can you tell me more about how your religion is going to impact the pregnancy choices? So this is all, and same for Jehovah Witness, especially since they're going to be losing blood. We're going to need to try to have a plan that's going to help, also incorporate the religion choices for this as well. Okay, so now we're on page 197, okay? So 197 in the book. All right, so let's talk some about abortions, okay? So this is not so fun stuff, okay? So, sorry, let me go back. Okay. Shoot, I don't know if I can go back. Darn it. Okay. Yeah, I don't think it's going to let me go back. It skipped a lot. All right, let me see if I can try to go back. No, it's not letting me. Okay. I can't go back, you guys. Okay. So what I'm going to do is we're just going to stay on this slide, but I was on the abortion slide, okay? I was actually on the abortion slide when this happened, okay? So just stay here because, like I said, it's not letting me go backwards on this. I don't like technology, okay? So basically, abortions, okay? I know that there's different laws about abortions and stuff, but there's different types of abortions such as, I mean, like I said, you can actually go back to the abortion slide. I think that's slide 71, but I can't go back. So go back to your abortion slide. So on your abortion slide, these are the different types of abortions that you can have. Induced, basically, and that's a procedure medication to terminate the abortion, to terminate the pregnancy. Elective termination at the request of the mother for non-medical reasons before viability. Therapeutic termination of pregnancy for medication indications or serious anomalies, spontaneous miscarriage, aka loss of pregnancy before viability. So yeah, the rest of you guys go back to slide 71 because it's not letting me go back, okay? So the thing is, I know that abortions vary, you know, it depends on the state, okay? But abortion is spontaneous or elective termination of pregnancy before 20 weeks gestation. And then on slide 71, it talks about the different types of abortions that you can have. Okay, now go to slide 72. Go back to slide 72. This is on page 198. It is not letting me go back, okay? And I don't want to mess this up, okay? So go to slide 72. Okay, so let's talk about the medical abortion, okay? So the medical abortion is used for um is going to be used for less than 70 days gestation. And this is preferred in women with fibroids, congenital issues, or a type of scarring. So medical abortion, what we're going to do is give a medication, okay? So we're going to give misoprostol, which is a need to know. We give misoprostol or Cytotec. This is commonly prescribed to induce uterine contractions to expel the remaining products of conception in the case of an incomplete miscarriage, okay? So medical abortion can cause bleeding heavier than normal for a period, severe cramping, nausea, vomiting, fever, and chills. You don't want to do a okay, so it's contraindicated in ectopic pregnancy, intrauterine device in place. That's like a birth control device. Corticosteroid therapy, chronic adrenal failure. So like I said, for the medical abortion, you're going to give the medication, misoprostol, and you need to make sure you know that that's going to help the body to contract to get the expel the remaining parts of the incomplete miscarriage. Okay, signs and symptoms. This is a need to know as well. So if you see the presence of abdominal pain or cramping along with vaginal bleeding, that can indicate a miscarriage is occurring. Fetal heart tones are typically not present or will be absent in a miscarriage. Patient will also have referred pain to the shoulder, okay? And what are some things you can say to somebody considering having an abortion? You can say something like, I can provide you with information about your options if you'd like, okay? So this is slide 72, okay? And all of this was neat to know. Okay, slide 73. Okay, slide 73, because like I said, I cannot go back and it's not letting me go back. A surgical abortion is going to be a D&C, dilation and cartilage. The cervix is dilated, the suction cartilage is inserted into the vagina, into the uterus, and it's going to vacuum and remove products of the conception. So the D and E is dilation and evacuation. That's done in the second trimester. The D and E fetus is removed through the vagina because the thing is, parts are going to be bigger. Suction is used to remove any remaining parts of the conception. Okay, on page 199, this is on slide 74. So on page 199, early loss, okay? So basically, so your early pregnancy loss and miscarriages is on slide 74, prior pregnancy loss, advanced maternal age, endocrine abnormality, drug use or environmental toxin, autoimmune disease, and infection. So these are your early pregnancy loss and miscarriage risk factors. So, systemic disorders, genetic factors, uterine or cervical abnormalities like fibroids or incompetent cervix, and also African American women are at higher risk for miscarriage. All right, so this is slide 74. Okay, and then slide 75. Go back to slide 75 because I can't go back. I'm sorry. Actually, I think we're caught up now. Okay, we're caught up now. Okay, so slide 70. I'm sorry about that, but like I said, it wouldn't let me go back. Okay, so I can't go back. So I gave you the slide numbers to go to. Okay, so now I think we're all caught up. Okay. All right, so we're on slide 75. So assessment findings for early pregnancy loss and miscarriage. So this I want you to know, okay? So uterine bleeding first, then cramping, abdominal pain in few hours to several days later. Vaginal bleeding and abdominal cramping, miscarriage, spontaneous abortion commonly presents with bright red vaginal bleeding, abdominal cramping, and passage of tissue. Absence of fetal heart tones may indicate fetal demise, but not necessarily a miscarriage. Bright red vaginal bleeding and passage of tissue. So these are things that you're going to see in the loss for early pregnancy, loss and miscarriage. The ultrasound is going to confirm the diagnosis, and serial HCG tests are going to reveal decreasing levels. So I want you guys to know the signs and symptoms and things that you're going to see with the early loss and miscarriage. And I'm sorry that things are so heavy. This is not so fun to go through, okay? All right, expectant management. Expectant management. This is on page 199 in the book, okay? So expectant management. So, for women without medical complications or symptoms requiring urgent or surgical evacuation, treatment plans can safely accommodate patient treatment preferences. So, you want to be sure that you know your medical management. Like we had said earlier, it's going to be the misoprostol cytotec that's going to be given, okay, to help get out any tissues, and it's going to help to evacuate the rest of the products in conception, okay? So be sure to know the medical treatment. So for Rh negative women, they're going to need RhoGAM within 72 hours of any procedure or medical treatment. Therapeutic communication, okay, so you need to know this well. Okay, so if a patient just had a miscarriage, what are you going to say? I want you guys to think about what you would say. You could say something like, I'm here if you would like to talk to me. I'm available to listen if you want to talk. What do you say to patients who feel that it's their fault? These are things to think about. This is why I stress therapeutic communication all the time. You could say something like, it sounds like you're feeling a lot of guilt. Would you like to talk about it? And all of this is need to know, okay? You could also say, this must be really difficult. Would you like to talk more about your feelings? um, Allowing clients to express her feelings and emotions during a difficult time, offering to listen, acknowledges the client's grief, and provides an opportunity for her to share her thoughts, which is crucial for healing. And also, page 200. This is for nursing care related to early pregnancy loss as well, okay? So that's good information as well. All right. So I hope all of this is coming through. I'm really sorry about any problems we've had so far. Okay, so on page 200, let's talk some about ectopic pregnancy, okay? So, ectopic pregnancy, this is a pregnancy that occurs anywhere outside of the uterine cavity, may also occur in ovary, cervix, abdominal cavity. All right, so basically you can see on the slide, so the pregnancy could be in the ovary, it could be in the abdominal, and the fallopian tube, and intestines. The thing is, it has to be in the uterus. If it's not in the uterus, the baby's not, you're not going to be able to have a viable pregnancy. Okay. So on page 201, you can see the figure, you can see the figure um, 7-12, which is the same figure on the slide. So as the egg grows, it could cause the tube to, so let's think in terms of if the baby is in the fallopian tube. As the egg grows, it can cause the tube to rupture and burst, causing a hemorrhage. So ectopic pregnancies will not be viable delivery. A baby cannot be formed properly anywhere besides in the uterus, okay? So this is why the baby has to be in the uterus. Okay, page 201. Let's see, what is endometriosis? What is endometriosis? Endometriosis is a chronic and painful condition in which the tissue, similar to the lining of the uterus, the endometrium grows outside of the uterus, okay? So, and this is what I want you to know. I want you to know what endometriosis is. It can lead to inflammation and scarring of the reproductive tract, and it's going to be very painful, okay? And you'll see this as well. This can lead to pelvic or abdominal surgery, STIs, prior tubal surgery. What are some additional risk factors that can increase a woman's risk? Cigarette smoking, exposure to drug distillio during the mother's pregnancy, increased age. So these are things that can also cause problems, with the tubal pregnancy. Okay, so page 201. So these are some signs and symptoms I want you guys to know for ectopic pregnancy. So you need to know what ectopic pregnancy is, and here's some signs and symptoms I want you to know for this, okay? Shoulder pain is a classic sign. Shoulder pain is a classic symptom of a ruptured ectopic pregnancy, resulting from blood irritating in the diaphragm. Additional expected findings include unilateral abdominal pain, dizziness, sharp stabbing, pain in the abdomen, and vaginal spotting or bleeding. Okay. Salvingectomy is a surgical removal of one or both fallopian tubes. After this, after this procedure, getting pregnant is usually more difficult. There are several reasons to get a salvingectomy, such as preventing ovarian cancer, ectopic pregnancy, tubal blocking, or infection. I want you to know, your treatment. Methotrexate will dilute the ectopic mass. So I want you to know methotrexate is an antimetabolite and a folic antagonist used to treat ectopic pregnancies by stopping the growth of rapidly dividing cells, thereby allowing the body to reabsorb the pregnancy tissue. It is important for nurses to understand that early detection and treatment of an ectopic pregnancy are crucial to prevent complications such as rupture and internal bleeding. I also want you to know side effects of methotrexate. It can be GI upset, including nausea, vomiting, and abdominal pain as common side effects. So I want you to be sure to know your treatment for this, okay? And make sure you know your signs and symptoms, such as lots of bleeding, expected findings, shoulder pain. That's a classic symptom of ruptured ectopic pregnancy, and additional blood, lots of bleeding. You, lower abdominal pain, dizziness, sharp stabbing pain in the abdomen, and vaginal spotting. And also make sure you know your treatment, methotrexate, and make sure you know, some side effects of methotrexate like GI upset, nausea, vomiting, abdominal pain. These are common side effects. And what they typically do for unstable hemorrhage is we have to go in and remove the part. Like I said, if it's in the fallopian tube, they'll go in and take out part of that tube, okay? I know this is a lot of information, okay? All right, so the next thing we're going to go over is going to be our gestational trophoblastic disease. This is on page 202 in the book. So we also call this the molar pregnancy, hydratidifform molar pregnancy. So the woman may show a baby bump sooner, than expected. There will be no fetal detected heart rate. It is not considered a viable pregnancy. There's no fetus. What it is chorionic villi into fluid-filled cysts. Cysts appear grape-like and grow rapidly. You're going to have increased risk for carcinoma, such as HCG. Must refrain from pregnancy for 1 year to monitor HCG levels. So this is not a viable pregnancy. It'll look like a pregnancy. You can pass a pregnancy test because the HCG level rises, but it is not a viable pregnancy, okay? And so the thing is, people think that this is a pregnancy and it's not, okay? So there's no heartbeat. It's just grape-like cyst, okay? So let me show you a picture of this. Okay, so this is a picture. This is not a pregnancy. This is the molar pregnancy. And so people think they're pregnancy, but these trophoblast cells, they can mimic a pregnancy. So in a normal pregnancy, the trophoblast cells develop into the placenta and have chorionic villi that form the endometrium. With a hydratidform mold pregnancy, there is a proliferation of placenta and trophoblastic cells which absorb fluid from the maternal blood. So, like I said, it looks like a pregnancy, but it is not a pregnancy, okay? You have the baby bump, and like I said, you can pass a pregnancy test, but like I said, this is not a viable pregnancy. It is not a pregnancy, but unfortunately, a lot of people think they're pregnant, okay? So the thing is, you have to take I think you have to take a medication to dispel the parts, but this is it's really hard for a mom because she thinks that this is a baby and it's not an actual baby, and it's really hard. Okay, so like I was saying, this is a molar pregnancy, so it's not an actual real pregnancy. You think you're pregnant, but you're not, okay? And like I said, when a mom finds out that this is not a real baby, she's already bonded. She already loves the baby, and it's just really hard. So, but this can be cancerous. So, like I said, this is just something that I want you guys, just to be aware of. Okay, I'm back. I've had some issues with recording, so I hope everything is going okay. So we're on slide 83, and this is page 203 in the book, okay? So we're going to talk some about the torch infections. So on page 206 to 207 for table 7-5, this is a summary of the fetal and maternal effects with infections. So what I want you guys to know, this is neat to know, okay? This substance can cause damage to the brain of the growing fetus. Early detection of torch infections such as toxoplasmosis, and this is on the slide, toxoplasmosis, others such as Hep B, rubella, cytomegalovirus, and herpes simplex virus can lead to serious complications such as developmental problems, miscarriage, or congenital defects if transmitted to the fetus. The first 8 weeks highlights that the first trimester, particularly in the initial 8 weeks of gestation, is the most critical period for teratogenic effects. During this time, major organs and systems are forming, making the fetus especially susceptible to teratogens, which can lead to significant birth defects. They can cause intrauterine growth restriction, prematurity, chronic postnatal infection, mental retardation, cerebral palsy, seizures, neurosensory hearing loss, and death. This is more neat to know. Torch infections can lead to serious health issues for the fetus if not identified early. Early exposure to torch infections can lead to developmental problems, miscarriages, or birth defects. Early detection of torch infections can prevent complications for the fetus. And remember, what I told you for HIV. So, what do you think we'd want to talk to the mom about in terms of the baby? And this is something we've already talked about. So, if a mom is HIV positive, we have to have the mom to take antiretroviral therapy, ART, so the baby can get some of the treatment prior to delivery. This will decrease the risk of transmission to the fetus. And like I said, there's a chart on page 208, and this information should be in there for HIV, okay? So this is all need to know information about the torch infections. And remember, when did I say that the baby is going to be most susceptible to infections and issues? Do you guys remember? We talked about this too. And the first 8 weeks of gestation, because that is the most critical period for teratogenic effects. And during that time is major organs and systems are forming, making the fetus susceptible to teratogens, which can lead to significant birth defects. So that's also, all of this is neat to know, okay? Okay, now we're on page 211 in the book, okay? So now we're going to talk about GBS, which is group beta strep, okay? And I hope everything's going okay with this because it's giving me issues, just so you know, but I hope it's all coming out okay for you guys, okay? All right. So, this is on page 211 in the book. So group beta strep. Now, has anybody seen this? Has anybody seen this? So, if the GBS status is unknown, we want to treat it as positive. So, group beta strep is a common bacteria in the female genitalia, it's and also in the rectum. It is the leading cause of newborn infections, okay? So we do the GBS screening, vaginal and rectal culture between 36 and 37 weeks gestation. If they're negative, cool, okay? But if they're not, then this is something we have to treat during pregnancy because we don't want it to go to the baby. So if the bag of water is intact and we're having a C-section, we do not need to worry about it even if it's positive. But what I want you to know for this is GBS screening, vaginal and rectal, is done between 36 to 37 weeks. And if it's what we're going to do, we're going to administer, like I said, still need to know, we're going to administer intravenous antibiotics during labor as ordered. Penicillin will be given prophylactically during labor. Penicillin will be administered during labor to prevent neonatal infection. GBS is treated during labor with ampicillin or either penicillin G like cefazolin if allergic to penicillin. We need two doses 4 hours apart and within 4 hours of delivery, or we need to receive another dose, okay? So then this is all need to know still. So GBS at 36 weeks gestation is standard practice to screen for group beta strep decoccus, as it can be a significant risk factor for neonatal infections if not treated during labor. So this is all neat what we need are going to need to know for this, okay? Okay, so now we're going to talk some about GBS risk for the neonate, okay? So why would the baby be at risk? What do you think? What do you know about babies? The thing is, babies are going to be at risk for a lot of different things. So this is why we have to closely monitor the baby. So we want to monitor CBCs, culture, and we want to monitor and treat the infections, okay? So they could be at risk for sepsis, meningitis, and pneumonia. So these are things that we would worry about for the baby. So the thing is, if the baby if it was not treated, then we'll need to do CBCs and cultures on the baby to treat the infection. And the thing is, just because mom wasn't treated, the thing is, baby may not automatically have these infections, but the thing is, we're still going to monitor and we're going to want to do these tests so we can kind of see if the baby is, and if the baby has it, we're going to go ahead and treat it because the baby's probably going to need to be on antibiotics. All right. Is everybody still with me? Okay, so now we're on page 225 in the book. We're on page 225 in the book, okay? So we're going to talk about substance use, okay? So how does substance use affect pregnancy? Is this good for pregnancy and how can it affect the baby? So some of the things that we're looking at is smoking and tobacco use, marijuana, alcohol, illicit drugs. So we're going to be looking at all of these different things because all of these things can affect the pregnancy and can affect the baby. Because remember what we said, when is it, in the pregnancy when baby's most susceptible? We just said it. 8 weeks, because the thing is the organs are starting to develop. So if you're doing drugs, then it's going to be affecting the baby even early in the pregnancy. Okay, so we're on page 227 now, okay? Page 227. So smoking and tobacco. Let's take a look at how smoking and tobacco can affect the baby. Okay, the thing is you're going to be at increased risk for several things because this can cause vasoconstriction. So we're going to encourage the woman to stop smoking if she's smoking. Um, and think about what are some risks to the mom and baby. So here are some risks to moms and baby, and I want you guys to know this, okay? So this is also needs to know. So we're going to be at risk for low birth weight, preterm labor, preterm birth, SIDS, sudden infant death syndrome, placenta previa. Do you guys remember what placenta previa is? We talked about that earlier. So if you don't know, look it up because I'm not going to tell you. Placenta abruption. What's placenta abruption? I said that was a need to know. Placenta abruption is when the placenta becomes detached from the wall, okay? So like I said, this is why with the need to knows, I don't want you to just know it, you need to understand it, okay? Because if you don't understand it, you're not going to be able to apply it. So some more need to know. Preterm labor, low birth weight, placental abruption, increased likelihood of stillbirth, okay? So these are some serious issues that we can end up having, okay? Okay, so now we're on page 228 in the book. We're on page 228. All right, so is marijuana okay for pregnancy? What if it's legalized? Is it okay? Yes or no? Is marijuana okay for pregnancy? No, it's not okay. So think about the changes to the body that happens. Normal changes to the body, and then you add additional issues due to substance abuse. So marijuana, which is a need to know, marijuana can cause brain damage to the baby in utero. Marijuana in any form can cause damage to the brain of the growing fetus. So any type of marijuana, okay, can cause issues to the baby. It is not okay. Even if marijuana is legalized in the state, it doesn't matter. It's not good for the baby, okay? And marijuana is the most commonly used drug in pregnancy. It can cause tachycardia and low blood pressure. It also increases the risk for orthostatic hypertension. And then you see the different problems. CNS abnormalities, IUGR, SGA means small for gestational age, LBW, low birth weight, and prematurity and stillbirth. So these are the different problems because marijuana can cause issues to the brain for the growing fetus, and it can also cause brain damage to the baby in utero. So these are things that I'm going to want you to know, okay? Okay, alcohol. We're still on page 228, okay? Now, is it okay to have alcohol during pregnancy? What about the first trimester? Because I know there's an ugly myth out there that says alcohol is okay in the first trimester. It is totally not okay because remember what we said. Basically, the baby's going to be susceptible for infections in the first 8 weeks. That's the first trimester. So no alcohol either. That is not safe, okay? So no alcohol during pregnancy. I don't care who says it because I know back in the day, people said a little bit of alcohol is okay in early pregnancy. No, they lied, okay? And they're wrong and canceled. So this alcohol can cause fetal alcohol spectrum disorder in newborns, and this is a need to know. Alcohol use during pregnancy can lead to serious developmental issues for the baby, including fetal alcohol syndrome. Fetal alcohol syndrome, low birth weight, developmental delays, and increased risk of miscarriages. Alcohol consumption during pregnancy can lead to fetal alcohol syndrome characterized by physical and cognitive impairments. So no amount of alcohol is safe, and alcohol is a teratogen, okay? So you want to make sure you know all that. Okay, now we're going to talk about more illicit drug use. This is on page 229. Okay, is any type of drug use safe for pregnancy? No, it's not. Okay, illicit drug use includes cocaine, amphetamines, and heroin. So, is any of this good for pregnancy? I'll answer no, it's not. Okay, and this is need to know for you. Okay, so I want you guys to know what illicit drug use can cause in pregnancy. It can cause preterm labor, premature rupture of membranes, placenta previa, placenta abruption, and low birth weight. These risks are associated with substance use disorders during pregnancy. The use of amphetamine and cocaine can lead to a variety of adverse pregnancy outcomes due to their effects on maternal health and fetal development. Okay, so like I said, it can cause all sorts of problems for the baby and also, and for the mom too, because placenta previa, placenta abruption is going to cause bleeding, okay? So it can cause preterm labor, premature rupture of membrane, placenta previa, placenta abruption, and low birth weight. These risks are associated with substance use during the disorders during pregnancy. The use of amphetamines and cocaine can lead to a variety of adverse pregnancy outcomes due to their effects on maternal health and fetal development. So how do you bring this up with your partner? You don't want to be like, "Hey, you're using drugs." You want to bring it up kind of you want to say something like, "Let's talk about resources to support and help you stop drug use during your pregnancy." So that's a therapeutic way of bringing that up. And it's always good to know your therapeutic communication. So let's go ahead and say that's a need to know as well. Let's discuss resources and support to help you stop using drugs during your pregnancy. Also provide non-judgmental support and offer resources to help the client stop using drugs during pregnancy. Okay, so these are things that I want you guys to remember. Okay, yay, we're almost done. Woohoo! Okay, so now we're going to talk about opioids. That's on page 230. So neonates withdraw from substance and are scored to determine treatment. Has anybody seen babies in the NICU going through withdrawals in the NICU? How were the babies acting? They were probably inconsolable. They probably cried a lot. They probably, and you have to monitor them, to kind of see how they're doing. So heroin and misuse of prescription opioids, analgesic meds, that can cause neonatal abstinence syndrome. It's not, so the baby's going to be withdrawing, okay? And that's not what we need. And these poor babies are going to be crying. They're going to be inconsolable. You're going to have to hold them all the time. So that's what opioid use can do for pregnancy. Okay, so now we're going to talk about risk to the woman, risk to the woman with substance use disorder during the pregnancy, okay? And these are need to knows, okay? So the thing is, you know, if it can cause all of these different things, okay? Risk. And for smoking, like we said, like I said, need to know, smoking can lead to preterm labor, preterm premature rupture of membrane, placenta previa, placenta abruption, and low birth weight. These risks are associated with substance use disorders during pregnancy. The use of amphetamines and cocaine can lead to a variety of adverse pregnancy outcomes due to their effects on maternal health and development. So this is need to know, okay? Make sure you know what smoking can do, the drugs can do, the things that it can lead to. All right, last slide. I really hope all of this came through. I really do, because I've had Dr. C has been struggling over here, okay? So I really hope everything has come through okay. So this is intimate partner violence, okay? And this is also need to know. So what is intimate partner violence? This is when your partner is abusing your abuse from the partner, okay? Who should be screened? All pregnant women, okay? And like I said, this is need to know. So all pregnant women need to be screened for this. The U.S. Preventive Service Task Force recommends routine screening for intimate partner violence in all pregnant women, regardless of their history or risk factors. Early identification Early identification and intervention can help ensure the safety and well-being of both the client and developing fetus. More need to know. Intimate partner violence can escalate during pregnancy and pose serious risks to both the pregnant individual and the fetus, including preterm labor, low birth weight, and maternal injury. Routine screening is recommended at multiple prenatal visits to ensure ongoing assessment. Screening should occur regardless of visible signs of abuse, as many victims do not have physical injuries. This should have they should have this at every prenatal appointment. Routine screening can help identify clients at risk for intimate partner violence. So all of that is neat to know, okay? So I think this is the last slide. Thank you for hanging in there. Like I said, Dr. C has really struggled, okay? I've been getting cut out, I've been getting kicked out. So I'm going to save this and post this, okay? But like I said, please be sure to let me know if you have any questions about this, and we can also go over any questions on Tuesday in class or whatever when we do the review. But I really hope everything uploaded. I really hope everything's okay, because I'm going to go ahead and start to try to save it and get it sent over now, okay? But thank you guys for hanging in there. Be sure to review this before class on Tuesday, okay? And go back over the other stuff that we've reviewed as well. Because like I said, the review, I want you to participate. I don't want to ask questions and you're just looking at me, because I'm just going to look at you back, okay? So anyway, let me know if you have any questions. Let me know if you need anything. And remember the inspirational saying for this week, stay dedicated. Have a wonderful day. Bye.